which is non-invasive testing in MASLD. And for this session, I would like to invite the chairpersons, Dr. Ramesh Ruprai, Dr. Ramesh M., Dr. Nagarjun, Dr. Nitin Behel, Dr. N. Arun, and Dr. Sanjay Banerjee. Can I request you all to please take the stage? And to moderate this session, I invite Dr. Uday Singh Patil and Dr. Sabu K.G. So when we were making this program, actually we debated amongst ourselves whether we should keep a talk on NITs or not. Some of us felt that it's probably outdated, and some of us felt that the conventional NITs. And some of us felt that, you know, in a resource-limited country like ours, probably they are still useful. So we will start off with an exciting debate. Are conventional serum-based NITs still relevant in clinical management in MASLD? And for this motion, I invite Dr. Samir Shah from Gleneagles Hospital, Mumbai, who will speak for the motion.
So the topic for which I am speaking is, are conventional serum-based NITs still relevant in clinical management of MASLD? So I'm impressed at the preciseness of the topics. So we are not talking about all NITs, we are talking only about conventional. So I'm not going to talk about unconventional NITs, fibrometer, fibrotest, NIS2, MAC3. Now there are newer NITs, not just FIB4, FIB9, FIB11, FIB12. So I'm not going to talk about all that. It has to be serum based. So I'm not going to talk about FibroScan, MRE, or FAST and MAST, which is along with the FibroScan and MRE. And it is clinical management of MASLD. So we are not talking about clinical research, we are not talking about clinical trials. So let us focus on the topic. So which are the situations in clinical management of MASLD where the NITs would be required? Now, we would be looking at patients who come to us in our gastro or liver clinics. But there is a huge general population, and we have heard that 30 to 40% of the general population would have MASLD in them. There is a huge load in the diabetes and the obesity clinics. So all these patients there would be having MASLD, and we need to have tests which should pick up those patients. We should not be just focused on those who are coming to us. Finally, actually all the NITs were validated because they wanted to do clinical trials in new drug development. So when they wanted to look at drugs which would reverse fibrosis in patients who had severe fibrosis, there they validated this non-invasive test. So amongst the non-invasive tests, if you look at tests which have got high sensitivity and specificity to look at severe fibrosis, then two tests only stand out, the FIB4 and ELF. So when you are considering a non-invasive test, either it can be the first line, which is a straightforward, clean, black and white. So you have a cutoff in one test where you can rule out fibrosis, and the same cutoff can say that above that level is cirrhotic. That never happens, you know that, because it is a full spectrum from F0 to F4. So you cannot have just one test and one cutoff where you will be able to say that, okay, below this cutoff, it is all normal, no fibrosis. Above this cutoff is all fibrosis. That doesn't happen. So you will need to have two cutoffs. The lower cutoff where you can reasonably say that there will be no evidence of fibrosis, and the higher cutoff where you can say that yes, there will be high chances of fibrosis and there is an intermediate zone in between. So that is what is usually possible with one test. Or you can have two tests. When there is a discrepancy between the two tests, that becomes the intermediate zone. So this is the way non-invasive tests can be interpreted and used in clinical situations. So this way, there was a prospective evaluation of a primary care referral pathway created, and this publication was in 2019, where they used FIB4 to screen the population coming to these hospital, and they used a lower cutoff of FIB4 of 1.3. So below that 1.3, they felt that significant fibrosis was not likely, and these patients need not go to a gastroenterologist or a hepatologist. There was another cutoff of 3.25, above which they said that yes, patients should go. And there was an intermediate between 1.3 to 3.25, where they said you can do another test called ELF to find out whether these patients should go to the hepatologist or not. So this was the sort of pathway which was created. We thought there was a basic problem with this, because the lower cutoff of 1.3 actually was derived to look at severe fibrosis. You can't have in the population floating around with severe fibrosis whom you can say that don't go to gastroenterologists, these diabetes specialists will look at. So we looked at in our population what should be the cutoff, where below that cutoff you can say confidently that you will not have any chance of fibrosis. And we looked at FIB4 versus biopsy, and we found out that instead of 1.3, 1.0 cutoff had a AUROC of 0.96. It had 100% sensitivity and it had 94% specificity. It was actually close to MR elastography, which is considered the gold standard for non-invasive testing. So with this 1.0 cutoff, you could confidently tell that this patient does not have significant fibrosis F0 or F1, and you can safely treat in any liver clinic, in any diabetes clinic, and does not need a gastro or a liver reference. This cutoff of 1.0 was accepted in the INASL guidelines also. The FIB4 has now been validated in a much larger cohort of 2,500, and this is Arun Sanyal's paper in CGH in 2023, where they have found that if the cutoff is less than 1.3 or is class A, 1.4 to 2.6 that is class B, and greater than 2.6 is class C. So three different classes: low risk, medium risk and high risk. In all the three, you could actually look at that, you could validate it, and there was clinical outcomes which were much higher in the class C and class B compared to class A. So finally, are conventional serum-based NIT still relevant in clinical management? Yes, let us forget that only we are treating patients with fatty liver. There is a huge chunk of patients in the general population, in the diabetes clinic and the obesity. And if we can have a cutoff like 1.0, where you can confidently tell our diabetes colleagues, our metabolic specialist, or people who are having a health checkup, that below this cutoff, you need not worry, there will not be any significant fibrosis, but the rest you need to focus. I think that is something which is going to be very important, and that you cannot do fibroscans or MREs all over the country. You need a simple NIT to do that, and that is my point. Thank you.
Now we'll have Dr. Anil Arora try to convince us that these tests are not relevant.
At the outset, I'm extremely thankful to Dr. Chaudhary and his team for this opportunity. The topic, as mentioned by Dr. Sameer, is very relevant. Our conventional serum-based NIT is still relevant in clinical management of NAFLD. Just to recapitulate, Dr. Sameer never mentioned what is it going to do in clinical management. The only thing is managed to tell us is how to send back the patient or he doesn't need treatment. There is not a single word mentioned by Dr. Sameer as to who needs treatment. The burden of the liver disease all over the world is about 2 million deaths occur per year due to liver disease. Every third individual in the world is suffering from fatty liver disease. So we need to have markers, especially those which can tell us which is the subgroup of the patient who need treatment. Serum biomarkers is the topic of debate today. They could be the conventional markers, which as Sameer has talked of, and then there are the proprietary markers. So what are we looking for when we look at the serum biomarkers? Do they tell us about the steatosis? Do they tell us that there is a steatohepatitis? Do they tell us that there is evidence of fibrosis? Do these markers tell us that the patient is suffering from cirrhosis of the liver? Do they ever help us in prognosticating the patient? Do they ever help us in follow-up of these patients? I'll give you that background. Let's start with the serum markers which are used conventionally to look at the markers of steatosis. These are the different markers: FLI, NAFLD, HSI, and steato test. Because of the shortage of time, I'll not go into the details. This is the summary. None of these these serum markers have been validated against liver biopsy and imaging methodologies. They underperform in patients who are diabetic. In fact, 70% of our patients with fatty liver will have diabetes, and those who are obese. So in addition, these serum markers will never be able to quantitate the amount of the fat in the liver. Let's talk of one single marker which tells us about the quantity of the fat and the quantity of the fat in the liver. Even if you look at 12 different serum markers to look at the evidence of fat in the liver, they are affected by the comorbidities, they are affected by BMI, and till date, none of these so-called markers, which has a composite of 12 markers, have been validated in cohort of patients with MASLD. Do they tell us about steatohepatitis? These are the markers which have been used in various labs and the clinical armamentarium to look at the degree of steatohepatitis. That is something which bothers us as clinicians. Most of these have not been externally validated, and they are expensive, they are not easily available. Let me talk of at least one serum marker which has been mentioned for diagnosis of steatohepatitis. So many markers, difficult to get onto, not standardized, limited availability of these markers, and the studies have not consistently shown their utility in clinical armamentarium. Do these markers tell us about the fibrosis? So these are the various markers which Sameer has mentioned. We have talked of APRI, we have talked of NFS, ELF, and the FIB4. Starting with APRI, very easy for anybody to say, oh, pick up an APRI, any reading of say more than 1.5 is significant fibrosis. But I think platelet count in general public may be affected because of the different reasons. Age may be another criteria, and AST may be elevated because of the reason other than fatty liver disease. And they, in general, do not have a good prognosis in patients with fibrosis of the liver. FIB4 is something which has been touted as one of the best markers to diagnose fibrosis in patients with fatty liver disease. But my dear friend should remember that it is affected by the age. We are still not sure of cutoff. Even though this marker has been used for the first time in patients with HCV and HIV for assessment of fibrosis, we are still grappling in the dark to know what is the cutoff. Is it 1, 1.3, 1.5? Age is something which will change the parameter. It is not valid in patients who are more than 65 years of age. There is no documented data in patients who are less than 35 years of age. So where does it lead us to? ELF is something which is one of the proprietary markers. And it still has not been validated in patients where the MFLD criteria has been utilized. We still do not know what is the cutoff of ELF. Is it 9.8, 10, 10.5? So still you keep on groping in the dark. The serum markers have been used for trying to look at the degree of fibrosis in various methodologies which are used. And if you look at the area under curve as well as the sensitivity and specificity, it is to the tune of about 0.7. That means 30% of the patients may be missing if you just bank upon serum markers to decide whether the patient has significant fibrosis or not. I'm sure you would remember this gentleman, Dr. Shalimar, who is heading hepatology at AIIMS. This is their publication. They have looked at all the published literature and have come up with this systematic analysis and look at the difference in the international as well as the Indian guidelines and the Indian data in terms of the poor sensitivity and specificity of these various markers. In addition, if you look at the impact of the BMI, as the BMI changes, look at the pathetic relevance of these markers in trying to assess the relevance of these markers in trying to diagnose patients with significant fibrosis. Do these patients do these serum markers tell us about the prognosis of the patient? Even if FIB4 is something else or APRI is a particular figure, does it ever give any information that how is the patient going to behave? Answer is just by looking at APRI and FIB4, you are comparing apple with oranges. There is something called Harrell C index, which tells us how relevant a particular test is in trying to prognosticate the patient. Do they help in treatment? Answer is no. In fact, the gold standard for assessment of response to therapy as well as the drug development is the MRPDFF, and only recently ALT-AST ratio has been brought into picture. But most of the trials do talk of reduction in the fat by the objective parameters, not the indirect parameters which are present in the blood. And look at the various guidelines. If you look at the AGA algorithm, there is hardly, other than ruling out the initial phase, if you go and clinically manage the patient, there is hardly any mention of any serum marker for assessment of the patient, for management and follow-up. Similarly, other than ruling out the patient with the early stage of the diseases, these markers have no relevance. And Dr. Sameer did show us about the Indian INSL guidelines. FIB4, once you have ruled out the patient, the topic of the debate is clinical management of the patient. I like to ask Dr. Ajay Duseja, where is in clinical management of the patient? Where do we have any serum biomarker popping up anywhere in the body? So I think, so far as I am concerned, the only purpose of doing a serum marker is whenever the patient walks into your office and clinic, do a FIB4. If it is less than 1.3, or if we agree with Sameer that it is 1, let him go back relaxed. Nothing needs to be done. If it is an intermediate range, anyway you need to depend on something else. That something else is FibroScan. And then if it is more than 2.6, in any case it is your baby, you are going to do something and clinically manage the patient. So to summarize, ladies and gentlemen, if you look at the role of serum-based NITs in management of MASLD, which is the topic, they have absolutely no role in assessing the steatosis in the liver. They have absolutely altered parameters in different studies when they look at them, and they also have marked limitation in staging and fibrosis as well as in diagnosis of steatohepatitis. There is a wide fluctuation in the reporting of the Western as the Indian data. There is absolutely no role in prognosis and follow-up of these patients. The only role is by ruling out the patient who have a low FIB4, of which we still do not know what is the cutoff. And reason for all this is they are variably affected by the metabolic condition, including inflammation in the liver as well as the presence of the fat. The AORC in the various studies is still pathetic, 0.5 to 0.75, which is not acceptable. They may have high false negatives in intermediate fibrosis stage. They do not have any prognostic value. They do not give any advantage in assessing the response to the therapy. And there is a significant difference in the Indian and the Western data. Thank you.
Dr. Sameer, can we have a quick rebuttal?
I have some slides for rebuttal just to sort of drive home the point, if I may have the slides. I think thank yous, Professor, for your second last slide actually is the final slide. May I have the slides, please? I can't see it here. You can take my second one. Yeah. So let us focus on the question. The question is there any relevance in the clinical management? I think the clinical management begins by trying to find out who needs treatment. So there is a large proportion of fatty liver in the community. We are just looking at patients who come to us. I think we need to look at those who are out there And who needs treatment? The patients whom we are treating who are in our clinics are only the tip. There is a much larger bulk which needs to be addressed. And in one bag there are apples and oranges. We will need to separate these apple and oranges, and we need to have a simple way of separating them. And I think this simple way is non-invasive test. You just separate out the ones who are going to progress versus the ones who are not going to progress. That is my final answer.
One last word from Dr. Anil.
I wish the debate for Samir would have been who needs treatment. Then I think your answer would have been justified. The question is, what is the relevance in clinical management? I fully agree you have a non-invasive test which has its own limitation. You only have a different cutoff from the cutoff which has been mentioned by Arun Sanyal. You have a different cutoff on what has been mentioned in the different international guidelines. It is affected by the age, it is affected by the obesity, it is affected by diabetes. There are so many confounding variables. And then you have equally good fibroscan which will give you equally good results. If the topic of the debate was who needs treatment, who does not, then Samir is the winner. If topic of the debate is what is the relevance in clinical management, I think let the audience judge.
Okay, thank you. I think that was an excellent debate.